Good afternoon, good day everyone, and welcome to this webinar that is co-sponsored by UNFPA India, the High Impact Practices Partnership, and the IBP Network. Today's webinar's topic is leveraging high impact practices in family planning for India's FP 2030 commitments. My name is Arus May. I'm a technical advisor at the IBP Network, and I have been involved in various roles with the High Impact Practices Partnership for the past 11 years. And it is my pleasure and honor today to moderate this webinar. Today's agenda brings together a very distinguished panel that will be opened by remarks from UNFPA India, from Andrea Wurschner, and followed by Dr. Pawan Kumar from the Ministry of Health and Family Welfare, Government of India. After these opening remarks, we will have a chance to hear from WHO on the high impact practices and WHO tools and the relationship between those two important tools. And then we'll go into more detail on three practices that are key to the work that is now taking place both at the national level as well as the state level in the country. We'll discuss adolescent responsive contraceptive services, post-abortion family planning, and digital health for providers. After the presentations, we'll have time for questions and answers. So please send your questions throughout the webinar, throughout the duration, so that we can prepare for those questions and give you answers if there is time. Then we'll have closing remarks by Dr. Prasad from UNFPA India. Before we begin, I'd like to remind everyone that the webinar will be recorded. You can submit questions anytime, as I mentioned just 2 seconds ago, and you can visit our website, fphighimpactpractices.org, at any time during the webinar to learn more about the topics that we are discussing. I have also put a copy of the presentation on the handouts, so you're welcome to download that from there, as well as a copy of the briefs from the topics that I just mentioned. Again, it is my pleasure now to introduce our speakers for the opening remarks segment, and I will. It is my pleasure to introduce Andrea Wurschner, who is the resident representative for UNFPA India and the country director for Bhutan. Andrea, over to you.
Thank you so much, Ados, and colleagues. Ladies and gentlemen, all, namaskar from Delhi. This is a really momentous moment for UNFPA and its partners, and I take really great satisfaction in knowing that so many distinguished partners and experts and stakeholders have been brought together on this common platform to discuss, to learn, and to absorb expert opinions and perspectives on high impact practices for family planning program. This collaborative effort was made possible through UNFPA's strategic alliance with the Family Planning Division of the Ministry of Health and Family Welfare, WHO's Implementing Best Practices Initiative, and the High Impact Practices Partnership. These all serve as a profound testament to our collective dedication towards the advancement of family planning initiatives. Further, today's agenda is really well aligned with World Contraception Day 2023, whose theme is the power of choice, the power of options, which emphasizes the vital role that contraceptive choices assume in granting individuals the ability to assert control over their own reproductive health. So I'd like to recall at this moment the profound words of the late Dr. Nafis Sadik, the former executive director of the United Nations Population Fund, who eloquently articulated in 1994 at the International Conference on Population and Development that healthy families are formed by deliberate choice, never by chance. So as we observe this World Contraception Day 2023, collectively, we will ensure that the goal of reproductive health becomes a matter of choice rather than a matter of chance. Empowering individuals to make decisions that shape their futures and their families' well-being is our shared objective. So, with regard to India's commitment to family planning, it has been steadfast, and its relentless efforts in pursuing the FP 2020 goals have yielded commendable success. I think we've all seen that, and have served as the bedrock for the nation's 2030 commitments. And these commitments focus particularly on improving the access to a range of contraceptives with the addition of new choices, improving healthy timing and spacing of pregnancies through post-pregnancy family planning, including urban areas under the Mission Parivar Vikas MPV, as well as intensifying social and behavior change communications for all age groups, but especially young people in this nation of the world's largest cohort of youth. And finally, engaging civil society organizations for awareness generation and mobilizing communities for family planning. India's impressive strides for increasing access to the adoption of modern contraceptive methods is reflected in NFHS 5 data. And family planning has played a vital role in curbing unintended pregnancies, as well as reducing the maternal mortality ratio from 130 just 8 years ago to 97 per 100,000 live births in 2018-2020, according to the sample registration system. So, knowing we've had these successes, where should future investments be? So despite these commendable accomplishments in achieving replacement level fertility and reducing the maternal mortality ratio, there are still disparities across regions. Poor indicators linger among specific population groups, including marginalized communities and those living in remote areas. Furthermore, with India's largest ever adolescent and youth population, at least until 2030, when the population growth tapers off, it's crucial to prioritize the provision of sexual and reproductive health information and services for this cohort as well. Globally, for the past 13 years, UNFPA has been playing a pivotal role by co-convening and collaborating with valued partners such as the United States Agency for International Development, the Bill and Melinda Gates Foundation, International Planned Parenthood Federation, IBP WHO here today as well, and FP 2030 on family planning high impact practices, each bringing its unique strength to support development and promotion of high impact practices and knowledge products. So our collective efforts aim to drive evidence-based, proven solutions for family planning that have demonstrated success in diverse global settings and multiple countries. So I'm delighted that we have people from India and beyond today to really share that information and that learning and expertise. The solutions that will be presented have been rigorously vetted and endorsed by the global experts of the High Impact Practices Technical Advisory Group. And importantly, these practices have been thoughtfully drafted to be flexible and adaptable to your own situations, ensuring that they are suitable within each distinctive country, region, and state context. UNFPA's unwavering support to align with the Indian government's vision and the FP 2030 commitments carries major potential for enhancing India's reproductive health landscape. One recent and noteworthy achievement that we're all quite excited about is the introduction of new contraceptives, the hormonal subcutaneous injectables and implants. These new contraceptive options will provide individuals with an even broader array of choices. And by ensuring affordability and accessibility, this initiative reduces further unintended pregnancies and supports those seeking, especially young people, to delay childbirth while pursuing their education and careers. We firmly believe that this webinar will be a catalyst for evidence-based programming that will help Indian states adopt relevant, high-impact practices to fulfill the country's FP 2030 commitments by choosing, adapting, and implementing practices with high impact as part of their state-specific roadmaps. This webinar will also provide insights into globally endorsed high-impact family planning practices, and specifically, as was mentioned before, address 3 practice briefs tailored to the Indian context, namely adolescent responsive contraceptive services, post-abortion family planning, and finally, digital health for providers, which has been so much a part of the discussions here through the G20 deliberations throughout this past year. The government of India, under its FP 2030 commitment, seeks to redefine the channels of service delivery for young people and to facilitate their access to contraceptives while upholding the principle of informed choice. The commitment also entails leveraging digital platforms to disseminate information and accelerate the ability to offer services that empower young individuals to make their own informed choices about preventing, delaying, or spacing births. So in alignment with the government's vision to create a digitally empowered society and knowledge economy that was also included under the G20 declaration that India presided over, it's evident that digital technology can also play a pivotal role in accelerating and supporting family planning providers to deliver high quality services. So we're living in exciting times, and it's at this crucial moment in India's trajectory. I firmly believe that India will not only bring high impact practices to advance sexual and reproductive health to new levels of success within the country, but will also emerge as a leading contributor of valuable evidence to strengthen global high-impact practice initiatives. So allow me once again to extend our profound appreciation to all the participants for your dedication to this crucial cause. Together, let us build a future in which every individual can exercise his or her inherent right to make informed choices about their reproductive health and rights. Thank you. Dhanyavad.
Thank you so very much, Andrea, for your remarks. And thank you again, UNFPA, for being a co-convener of the high impact practices from the very beginning. When this work started about 12 years ago, UNFPA was there to lead the way along with USAID and WHO. And it's a relationship and a leadership that we very much value. So thank you. Now, allow me to give the floor to our next speaker on the opening remarks segment, Dr. Pawan Kumar, who's the Additional Commissioner in charge of Family Planning and Maternal Health Division at the Ministry of Health and Family Welfare. Dr. Kumar, welcome.
Thank you very much for introducing me. Good afternoon, good evening, good morning to various region people wherever they are connected for this important webinar. Greetings from Delhi, India to one and all. Thank you very much. The me for this very important webinar today, where we will be discussing leveraging high impact practices in family planning for India FP 2030. Allow me to take you all through the historical aspect and current status of family planning, contraception, and sexual reproductive health in India and leveraging high impact practices. As we all know, India became the first country in the world to formulate a national family planning program in 1952, aiming to bring down the birth rate to a level that aligns with the needs of the national population stabilization. As time passed, this program experienced a fundamental transformation in its strategy, transitioning from a focus on population control to one centered on the provision of right-based services. Over the time, the program has undergone substantial development and is now firmly integrated into the holistic RMNCHA plus nutrition framework, which ensures a seamless provision of care across all life stages. Through its evolution, India has played a pivotal role in shaping some of the global high-impact family planning practices. FP 2020 injected essential momentum into the global effort to achieve universal reproductive health. India is resolute in its commitment to enhancing access to contraceptives, particularly in remote regions, diversifying the range of available contraceptive methods, bolstering supply chain through the family planning logistic management information system, intensifying awareness campaigns, reinforcing counseling services, promoting greater private sector involvement, addressing the unique requirement of the youth demographic, executing comprehensive media campaigns, and focusing targeted intervention in priority states through intervention like Mission Parivar Vikas, all while ensuring substantial financial support. Building on the FP 2020 momentum, India relentlessly worked over the last few years, and the concerted efforts paved the way for the attainment of FP 2020 goals. India successfully achieved its goal of modern contraceptive prevalence, demand satisfied by modern contraceptives, and total allocation of $3 billion by reflective of our successes. Furthermore, building upon the success of our previous initiative and aligning with the FP 2030 goals, we are keenly aware of the distinct challenges our nation faces, particularly with the presence of substantial young population. Consequently, our commitment to FP 2030 revolves around the principles of collaboration, convergence, and inclusivity. This commitment seeks to ensure enhanced access to wider range of contraceptives, including introduction of new options. It aims to promote healthy time of pregnancy through post-pregnancy family planning, expand the reach of Mission Parivar Vikas, intensifying social and behavior change communications, efforts targeting all age groups with specific focus on young people, and leverage the involvement of civil society organizations to generate awareness and mobilize communities in support of family planning. The FP 2030 initiative aims to tackle India's strategic priorities, which include meeting the family planning needs of vulnerable population, fostering greater male participation, enhancing access to and availability of services, and actively involving both communities and the stakeholders in these efforts. India has taken a pioneer role in implementing the evidence-based family planning high-impact practices, which are proven strategies that enhance the effectiveness of family planning and reproductive health programs. These strategies encompass service delivery, social and behavior change initiatives, and the creation of enabling environment. India's efforts in these areas have contributed significantly to achieving positive sexual and reproductive health outcomes. India has demonstrated global leadership by emphasizing the significance of providing contraceptive counseling and services immediately after institutional delivery. Since the initiation of postpartum intrauterine contraceptive devices program in the country, India has successfully inserted over 20 million IUCDs with an impressive acceptance of rate of 28%. The importance of women contact with healthcare system has been recognized. This continuum care approach leverages service delivery platforms such as immunization, adolescent days, village health and sanitation nutrition days for various reproductive, maternal, newborn, child and adolescent health plus nutrition component to offer integrated family planning and reproductive health services in the country. In accordance with the nation vision outlined in the Ayushman Bharat Digital Mission, aimed at establishing a digital health ecosystem that facilitates universal health coverage efficiently, inclusively, affordable, and safely, while providing an extensive range of data, information, and infrastructure services. We have created electronic modules for our source materials. These resources include the MP injectable manuals, OCP manuals, and WHO MEC Vahil and FP LMIS manual. The purpose of these digital resources is to augment the knowledge, capacity, and service quality of our family planning providers. Efficient supply chain plays a crucial role in ensuring the consistent availability of diverse range of contraceptive methods and facilitating voluntary and informed choices. Consequently, concerted efforts have been made to optimize the supply chain through the Family Planning Logistics Management Information System initiative. Presently, our FPLMI software boasts of registration of 0.2 million stores and 0.8 million ASHAs who play a pivotal role in ensuring the last mile availability and delivery of the contraceptives in the community. India has dedicated itself to enhancing the availability of contraceptives, especially in remote regions, broadening the array of contraceptive choices, fortifying supply chain using the boosting awareness campaigns, reinforcing counseling, fostering collaboration with the private sector, catering to the unique reproductive health requirement of the youth, launching comprehensive media initiatives, and directing focused efforts to high priority regions. The introduction of new initiatives and schemes has yielded favorable outcomes, prominently exemplified by the success of Mission Parivar Vikas scheme. This initiative primarily rested on the pillars of improved service delivery, social and behavior change interventions, and creating an enabling environment. The program has proven high effectiveness in reducing the fertility rates in high fertility districts in selected states by ensuring universal access to healthcare services, even in the most challenging regions. Additionally, our media campaigns targeting newlywed couples have ignited a fresh enthusiasm for family planning services within that community. All this investment has paid us a rich dividend in 59 million unintended pregnancies, 2 million unsafe abortions, and 21,000 maternal deaths as a result of modern use of contraceptives in 2022. The recent DHS data also serves as a reaffirmation of India's dedicated efforts and the consequent positive outcomes in enhancing reproductive health across the nation. India has achieved a significant demographic milestone with a total fertility rate dropping below the replacement level for the first time, 2 children per woman as per DHS data. Additionally, there has been a substantial increase in use of modern contraceptive, rising from 47.8% in DHS 4 to 56.5% in DHS latest data. Furthermore, the unmet need for family planning has decreased, dropping from 12.3% to 9.4%. These trends also reflect a favorable shift towards the adoption of spacing methods with an increase in usage of various spacing methods. Continuing our commitment to progress, the Ministry of Health and Family Welfare, Government of India, is involved in formulating and executing innovative interventions. We prioritize continuous learning by participating in the international and national forums, leveraging high impact practices from the other countries, and drawing upon initiative, knowledge, and skills shared. As we advance toward our FP 2030 commitments, our dedication extends to fostering resilient health policies that incorporate self-care, thereby improving health outcomes for all. This endeavor aligns with the achievement of Sustainable Development Goal 3, which seeks to ensure healthy lives and promote well-being for all individuals of all ages. Additionally, our efforts continue to the accumulation of further evidence for global high impact practices. Thank you very much. Over to you, Adosme.
Thank you very much, Dr. Kumar. And it's very impressive to see the trajectory of the government and the partners in India in promoting and implementing the high impact practices. As you were speaking, it reminded me of an effort that we were part of in 2018 when we hosted a regional meeting in India. And we also hosted for the very first time the CSO's FP 2030 at the time 2020 commitments that brought together civil society in India under the leadership of the Population Foundation of India and various partners. So thank you very much to you and Andrea for providing us with the opening remarks for this important webinar. And without further ado, I will then move on to our presentations and introduce our first panelists for the day, as well as give you an idea of the other experts that will be with us today. First, we will hear from Dr. Pragati Singh from WHO, then from Dr. Anand Sinha from the Packard Foundation in India, and then on post-abortion family planning from Dr. Sashwati Das. And we'll finish the technical part of the webinar with a presentation, a recorded presentation from Dr. Smicha Warla from Hopkins University, who unfortunately couldn't be with us in person, but had sent a recording. So now we will have an introduction on the high impact practices that will be co-presented by Dr. Singh and myself. Dr. Pragati Singh is a National Professional Officer at the WHO Office in India, Department of Sexual and Reproductive Health and Rights. You can read a little bit more about her vast experience from this slide. And with that, I will give the floor to you, Dr. Singh. Thank you.
Thank you, Ados. Thank you so much. And thank you to my speakers, Andrea and Dr. Pawan. Greetings from WHO Country Office for India. And as I said, I'm really grateful that my initial presenters has actually set the stage, and we are ready to move with a positive spirit. So before we actually come to what is HIP, and because me, myself, and Ados will be co-presenting on that, let's just rewind our thoughts on what Dr. Pawan and Andrea has highlighted. They have provoked us to a new pathway. They have told us that what India has come up with and what are our successes. Next slide, please. But next slide, please. Can I request next slide? Yeah. So we can't rest on our laurels, and you will agree with me, we have to chart a way ahead. What next for India? So the slide may look very busy for all of us, but I'm pretty sure that the India team knows about it. The country is in the stage 3rd of high prevalence. We are already in the stage where the increase in MCPR will eventually stop. And increasing the access will further require innovations. Innovations in terms of task shifting, investing in additional training health workforce, maybe engaging with the private sector or other innovative approaches. Country with the largest young woman cohort or the largest adolescent cohort definitely needs strategy that requires investments and intervention around adolescent and youth health programming. And in the graph, you can clearly see the green part. Very less of this proportion is using the modern contraceptives. Postpartum family planning, India has been the global leader for the postpartum IUCD, but definitely there is a long way to go. And as we reach to our benchmark, the path becomes more arduous, more difficult. So investment in PPFP, we need to chart our way ahead. Places with large proportion of postpartum women and not using modern contraception may require the focus. And this is the data that Track 20 actually tells us on FP opportunity during FP 2020. Moving on to NCIFP score, that is the National Composite Index on Family Planning, that tells about the enabling environment, a very telling graph. So in terms of strategy, we are well placed, but definitely strengthening is needed in terms of data, quality, equity, accountability, that is required. Next slide, please. And so I think it's moving. Okay, so FP 2030, yes, we successfully achieved our FP 2020 goals. All the best to the entire India country team, but FP 2030 vision document provides a bouquet of options for the strategic priority for the country. And there is a need to actually identify how it is to be done and what it is to be done. Next slide, please. And when I am saying that how it is done and what is to be done, there is definitely an answer. We all have an answer to it. Next slide, please, Ados. Now, what we need a consensus. Previous slide, Ados. That's a problem that usually we have in the virtual things, but I'll continue to speak. Previous slide, Ados. So we need a consensus and direction around what will work for the country. You can see in the picture, the roads are very difficult, many turns, many twists, and as we are proving ourselves to be the best, the country has difficult benchmarks for itself. So whatever we need has to be in the country context, and definitely WHO guidelines are there to complement it. The answer lies in the dotted box here, high impact practices that clearly lays down that what works in the FP intervention. But the caution, how it will work has to be charted in the country context, and that's where the role of a country and the country team is important. Next slide. So this entire conversation, next slide please. This entire conversation reminds me of a quote from Martin Luther King: a genuine leader is not a searcher for the consensus, but a molder of consensus. We have consensus, we have strategies, we have high impact practices, but how do we mold it for the country? That's where the art is. Next slide, please. So what WHO has to offer, next slide. Now, WHO has this WHO HIP matrix tools that provides the background matrix and WHO guidelines and tools. These are two separate documents, guidelines and tools. Next slide, please. And this is a simple 4-pager document that gives the entire background of how the tools are available to help you to achieve the high impact practices. So that there are 4 pillars that are addressed in this matrix: advocacy, program design, provider reference, and training. And we have the tools ready regular tools for the country for all these pillars. So for advocacy, there is a guideline that talks about the health workforce roles in task shifting, which you can also utilize during program design. And I'm happy to share India has done task shifting to an extent in various programs, but we have to innovate. We have to find out where task shifting is again required. Private sector can be one of them. Ensuring human rights and contraceptive provision. For program device MECV, you must be knowing about the standard practice recommendation, consolidated guideline on self-care intervention. Now that's a new thing and a very well required thing after COVID-19 pandemic. We do have guidelines on digital interventions for health system strengthening. For provider reference, every one of us is aware about this handbook for the providers. That's that I'll say that's a Bible of contraceptive methods and MECV. And lastly, on the training front, there is a training resource package. It's an online open system training resource package, and as you can see, it's a combined effort from various agencies like USA, WHO. So there are various things that are enlisted in the training resource package and can be utilized in the different settings. Next slide, please. So all these materials are available, and how to use these materials. So ADOS will be telling you about the different high impact practices. So one of the high impact practices talks about optimizing health workforce roles, talks about drug shops and pharmacies. So for drug shops and pharmacies, how do I find a right guideline or book? So there's a matrix to it. Optimizing health workforce role for task shifting guideline can be used as an advocacy or the program design for this particular high impact practice. practices. It's a very simple matrix and definitely very useful. Next slide, please. Next slide, please. And this is my last slide, which may be a very busy slide, but that's where we are aligning the country priorities with WHO guidelines. You can see the entire, these small pictures of entire guidelines that Government of India has come up with. I'm happy to share that every guideline in family planning is aligned with WHO Green Handbook. Some of the recent resources are on counseling material, COVID, parliamentarians, subdermal contraceptive implants. Andrea has also talked about these 2 new contraceptives. So WHO country office has been an integral part of the development of it, and MECV, country has adopted the MECV in the country context. And last but not the least, self-care. So we are now aligning the self-care efforts, the global efforts with the country efforts, and that's where the integration or the alignment is required. Now, this is my last slide, but I'm not saying it bye-bye, or I'm not saying the end, because definitely Ados will be talking about high impact practices, and I'm leaving you all with the thought that how it has to be done. What we know, how it has to be done, has to be answered. Ados, over to you, please.
Thank you so much, Pragati, and thank you so much for making the important link between the high impact practices and the WHO guidelines. So very briefly, I want to share with you and reiterate what we have discussed up to now. What are the high impact practices? They are evidence-based family planning tools that are vetted by experts against specific criteria, and they're documented in an easy to use format. When experts set out to put together these materials a few years ago, they gathered the evidence and decided that in order for them to be useful, they had to be short, less than 8 pages, and have the evidence and the resources available so that they could be useful for policymakers and for implementers alike. They are the authoritative synthesis of evidence in family planning. These are tools that can help countries achieve their sexual and reproductive health goals, and also assist policymakers and program implementers in identifying what works in family planning. And this is based on a rich history of implementation and policy making from around the world. In order for these practices to be considered a high impact practice, they have to demonstrate impact. They have to be applicable across settings, across geographies. They also have to demonstrate that they can be scaled up, often in the absence of outside donor funding, and that they're sustainable and cost effective. Our technical advisory group, that what we call the HIP stack, has put together the HIPs into 4 categories: enabling environment, service delivery HIPs, social and behavioral change, and enhancements. You can see here the categories for the HIPs, and we have shared through the chat a number of links that you can further explore these tools. And the HIPs partnership couldn't be possible without the support of our co-sponsors, and they are FP 2030, IPPF, UNFPA, USAID, and WHO. And the HIPs are approved and created by our technical advisory group, made up of about 25 global experts in family planning, who decide on the evidence and who make this work possible. We are very lucky today to have 2 of our speakers being TAG members. Dr. Anand Sinha and Dr. Sashwati Das are members of the technical advisory group. and they will be discussing with you some of the work on the hips. For more information on the hips, I invite you to visit our website and use the resources that we're sharing with you today, as well as others that are available for your use. And now I'd like to turn it over to Dr. Anand Sinha, who will talk to us about the Adolescent Responsive Contraceptive Services brief. And also, before we go to him, I want to thank all the people, all our colleagues who have joined us today, more than 90 people from India and across the region. And before we go to the presentation, I'd like to introduce Dr. Anand Sinha, who is the country advisor for the Packard Foundation in India, and is a technical advisory group member of the HIPS. Over to you, Anand, and thank you.
Thank you so much, Ados, and thank you to all the respective speakers who sort of laid out, I think, the framework of where India is in its family planning journey and the potential role and application of the HIPS. I'm going to be talking very briefly about one of the HIPS that is probably very high on the list of priorities for India, which is really trying to meet the needs of young people and developing an adolescent responsive contraceptive services. Now, one thing to remember again about HIPS is it is really very strongly evidence-based, and it's looking at ticking all of those boxes that Dr. Pragati was talking about in terms of, having achieved scale, impact, being, scalable in multiple countries. And so is typically well proven. The other thing to remember, however, is that this isn't everything that can be done for that issue. I often think of HIPS as being the bedrock, the essential elements, the must-have elements on which you can build a really strong program. And with respect to adolescent contraceptive services, I think this HIP specifically that I'm talking about deals with sort of delivery service aspects of providing contraceptive care and contraceptive services to young people. There are many other aspects, of meeting the needs of young people. It could be looking at, the education of girls, community engagement, men and boys, social marketing strategies. And those are covered in different HIPS. So one of the other things to remember with HIPS is that it's often a question of mixing and sort of melding a group of different high impact practices, sort of areas, into a more comprehensive strategy. But at the same time, next slide, please. At the same time, the high impact practices does try and sort of look at a more of a systems approach to looking at informing and improving contraceptive services. So it doesn't look at just specific interventions such as conducting training or specifically just adolescent friendly health clinics or others, but sort of looks at bringing all of those together at a health system level, which is quite important. Next slide, please. So I'm not going to go into a lot of the background of why this is needed. I mean, I think many speakers have talked about the size of of this group of the population of young people, their needs and their emerging needs, and I think it's just acknowledging that this is a distinct group from other age groups and that they face distinct barriers in terms of accessing contraceptive services. So I think those are well established. And again, specifically in India, I think our policy documents, particularly RKSK, sort of clearly outline where the needs are and where the barriers are. So these are well understood, and I'm just underlining these again. Next slide, please. And essentially what we're saying is that adolescent-friendly health services, when well designed and well implemented, can increase the use, access and use of contraceptives. And it can be, these services can be scalable and have been proven to be scalable and sustainable over time and over large geographies and over countries. And I'll give you some examples of what this looks like. Next slide, please. firstly, just to again go back to sort of, thinking about what does a systems approach look like. I mean, this is sort of, the basics of understanding a health system and all of the components of the health system and what are those building blocks. And the WHO health system building blocks are, these 6 broad boxes. And then how do we sort of think about the needs of adolescents underneath each one of those? Again, this is just sort of saying, what is the framework for looking at adolescent reproductive responsive contraceptive services? We have to address, do we have data that is disaggregated by age? Do we have, service delivery points and systems that adequately meet the needs of young people's specific sort of, situation? Privacy, providing complete information, providing a whole range of information. Do we have, a whole range of medical products and services? Do we have a whole range of contraceptives, right? Access to all essential medicines. Is the health workforce, competent, well-trained, non-judgmental, able to offer confidential services? Are services available for free, or are they at least subsidized and prices are reduced? And again, are adolescents and young people actually involved in decision making and in holding systems and providers accountable to the services that they demand and they need? I think sort of addressing all of this is, again, just a reminder of what health systems looks like. Next slide, please. So when the HIPS does sort of, the HIP tag goes through its process of looking at evidence to say what works, here are some of those sort of examples of the large sort of scale data that one is looking for that says, yes, okay, let's look at, specific countries, specific interventions across large areas and how they have been evaluated over a significant period of time. And we're able to sort of clearly assign some degree of causality to the interventions per se. This is some data that the HIP tag was presented from Ethiopia. And essentially what was happening in Ethiopia over this period of time that this data tracks, which is almost a 15-16 year period, was, policies were changed, policies were strengthened. HMIS specifically started to collect disaggregated data by age so that one could understand who was coming for what types of services. Training packages were specifically formulated and widely sort of rolled out to cover all types of health providers across all levels, including outreach workers. There was a variety of, service and outreach sort of platforms that were made available for adolescent services. Products were made available free to young people or at low costs. There was a broadening of the range of contraceptive methods that were offered to young people over this period of time. And there was an effort to make sure that all of this wasn't just on the shoulders of government and the public system, but really through also the engagement of NGOs, civil society organizations, and provider associations were brought together in the formulation of the programs, policies, but also in terms of sort of reviewing management and administration of these programs. So it was bringing together multiple sectors. Next slide, please. And what you see is the result of that is an increase in contraceptive use over that period of time within these age groups. Similarly, more data, another sort of data set coming from Chile, which looked again at not just increases in contraceptive use, but also decline in fertility rate amongst the age group of 15 to 19, which really clearly showed that the positive impacts were played out over this period of 10 years. And again, what was contributing to this? Many of the same factors, well-trained providers, making sure that adolescent-friendly health clinics were present in each PHC and were operational. Making sure that there were strong outreach programs and referral programs so that you could reach young people where they were and make sure that they could be then referred to where the services were. A very strong policy commitment to making sure that the HR and the financial resources that were required were made available. And the commitment was not for a couple of years, but the commitment was a sort of outlay for a period of 10 years that was made in the case of Chile. And again, age disaggregated data and ensuring that there was a complete method mix that was offered to young people as part of this program. Next slide, please. My final sort of, I think the example that the HIP document talks to, and actually the HIP document talks about many, many more examples of evidence, but just the ones that we're presenting here, is really one that sort of looks at impact across multiple countries and tries to say, what are the lessons, what are the key components? And many of these are the same things that I've been just listing out. So if we looked at what happened in Chile, in Ethiopia, even in Uruguay, what are the essential elements? One of the key things to understand is this requires a lot of advocacy. It requires a lot of advocacy because it requires a certain degree of helping people understand the data, helping people understand the need for this and why, meeting the needs of adolescent population is important with a reproductive health angle. There's a fair amount of pushback and there's fair amount of opposition. Why do young people need to think about family planning? Should young people even be, involved in sexual activities? Are we creating promiscuity? Young people are generally a healthy population. I need to think about more important, there are greater priorities in my health atlas of my country. And so, oftentimes the need to have advocates to make sure that, adolescent health services, adolescent reproductive health services is a priority, is a significant need. And was again one of those consistent learnings we had. And from that, you will get supportive policies. Again, there's a lot of need for strong communication and directive communication that tells people that, look, this is a program, this is how we're going to go about it, and getting everyone together. Many of these sort of lessons that we're seeing in this list are our general sort of understanding of how strong health systems work. Stakeholder participation, doing regular reviews and periodic assessments to see how well we are working, making sure resources are adequately allocated and available, and that scale up is effectively managed. But as you will look at that HIPS document, each time what we will do is that you will find certain sort of implementation tips or examples behind each of these, which tell us why, again, these are essential building blocks to building sort of adolescent responsive contraceptive services. Next slide, please. And Ados, will you tell me when my 10 minutes is over, or is it already over? I'm sorry, I may be going on so beyond my time.
You have a couple of minutes, Anand.
Okay, great. I'm just going to go through a couple of examples and slides here. So again, the HIPS document does talk about how one would measure effectiveness and impact of these programs. Here are some examples, sort of just simply the number of % of health facilities that actually provide adolescent contraceptive services. And again, this has to be measured not just in terms of their ability to provide, but it has to be measured in terms of actually having provided services to adolescents under the age of 20. Total number of contraceptive visits from people who are under 20 years of age, proportion of districts or other, whichever geographic district that country operates with. In our case, it would be districts, where 15 to 9-year-old people, 19 to year-old people have a designated place in community accountability mechanisms, right? So do they actually have participation in trying to manage and in trying to improve and holding these programs so that they are meeting the needs of their own community? Next slide, please. One of the other things the HIP tag does when it is sort of thinking about and developing these HIP briefs is think about what is missing, what information and what data are missing for us to be able to sort of develop a better understanding of the issue. In the case of adolescent responsive contraceptive services, it's these are 3 of the questions that have been identified as priority research questions, because the tag did feel that these have not been well enough understood and would be very, very important in contributing to sort of sharpening our understanding of what is a high impact practice. So what are the factors and systems, system conditions that allow for ARCs to be scaled up and sustained? What actions have government taken to integrate ARCs into a UHC program, and what were the results of those? What social accountability mechanisms, including those that are led by adolescents, could increase contraceptive responsiveness to adolescents as well? So again, you'll see this in each of these HIPs, is that it also does lay out a certain charter for researchers and for people who are implementing these programs to think about other questions that they could be answering. I think one of the most, next slide please, I think one of the most important parts of the HIP briefs that people look at is the implementation tips that come from these sort of, survey of literature and of looking at, what worked and how they have worked. And again, the implementation tips try to become a little bit more specific in terms of the actual elements of the programs or interventions that need to be present or that could be present. And that become much more useful for actual program managers and implementers. Here, I had put together a selection of these, and again, these are maybe a little bit generic. Use a wide variety of channels to make sure that you're providing these services. Integrate contraceptive services into other health services. So think about how do you get contraceptive services where adolescents might be coming to seek other services, whether it's HIV services, whether it's MNCH services, they might be coming. And consider, promising new modalities. Again, a lot of, I think we're going to talk about sort of digital platforms, self-care models, direct-to-consumer models that could be used. Next slide, please. And again, each time that the HIP brief talks about implementation tips, it also tries to back it up with data that says these are the reasons we believe that these tips are again high impact and proven to work. So again, just to say that employing a variety of sectors and channels was one of the implementation tips we saw in the previous slide. And these data here sort of tell us in different countries how having a variety or having a mix of different sources for methods has led to success, a successful adoption of different methods. Well, essentially saying that in Kenya, different methods are available more prominently at different service points by young people. So if young people are looking to use implants, they'll typically go to the public sector. If they're looking at using pills or condoms, they'll go to the pharmacy. And this is similar in India as well. We know that young people will seek different types of services from different types of outlets. It's not all going to be about everyone going to the public sector to seek contraceptive services, but the data is just sort of laid out here for people to be able to make that connection. There are a series of other implementation tips in here, and if you do download the presentation, you will see more of them. I'm not going to run through all of them just now, but collecting data, making sure we're collecting feedback, we're collecting disaggregated data, making sure we're thinking about the financial condition of young people. What can they afford? What can they pay for? And how much? And who needs to subsidize what? Doing trainings of providers. I think the idea of sort of whole site training and training all the providers together again are some of the other implementation tips I can remember off the top of my mind. But essentially, I think as we are thinking about constructing that program, and it's not a question of constructing that program. I think in India we have a well-constructed program and a well-implemented program in many places. But I think as we think about reviewing and strengthening that program, the HIP brief on this topic is again an essential element of just thinking about what are the building, essential bedrock elements of building a successful program. Thank you so much. Back to you, Edos.
Thank you so much, Anand. And again, thank you for your support to the HIPs and for this presentation. And now we are moving to post-abortion family planning, the next topic on our webinar. And this presentation will be led by Dr. Sashwati Das, who is both a member of the High Impact Practices Technical Advisory Group and the Sexual Reproductive Health and Rights Specialist at UNFPA India. Over to you, Sashwati.
Thank you, Edos. So, greetings from India. So, post-abortion family planning is one of the several high-impact practices which is vetted by a technical advisory group of international experts. Next slide. So this is a proven high-impact practice. Proven means it is based on strong evidences from multiple countries. And what is this practice in? practices states that proactively offer voluntary contraceptive counseling and services at the same time and location where women receive facility-based post-abortion care. So in Indian context, we have comprehensive abortion care facilities, CAC facilities, which provide abortion services, post-abortion care, and also other facilities, even the lower level facilities, which provide medical abortion services. So if post-abortion family planning counseling and services are in place at these facilities, this post-abortion women, they are likely to adopt a family planning method before leaving the facility, and it maximizes the return on investment under family planning program. Next slide. This is theory of change, that this slide shows that if post-abortion family planning counseling and services are provided, that most women leave the facilities with an effective family planning method, and this leads to the results of fewer unintended pregnancy and fewer women at risk of unsafe abortions. Next slide. So what is the rationale? Why is it important to focus on post-abortion family planning? Post-abortion women, they have the high unmet need for family planning. They either want to delay future pregnancies or want to stop future pregnancies. So post-abortion family planning, counseling and services addresses this high unmet need. And if a woman, if she chooses to become pregnant soon, then also she should be informed that according to health recommendation, she should wait at least for 6 months to lower the risk of premature birth, low birth weight babies, and maternal anemia. Then in subsequent slide, we will talk about that post-abortion family planning improves contraceptive acceptance and continuation. Post-abortion family planning also reduces unintended unplanned pregnancies, and it breaks the cycle of repeated abortions. The global data show that 20% of post-abortion clients, they admit that they have had an earlier abortion. So you can see how post-abortion family planning is important. And unsafe abortion, we all know that it's a major contributor of maternal mortality and morbidity. Next slide. So what challenges country can overcome through post-abortion family planning? Post-abortion family planning improves the reach of contraceptive counseling and services, because induced and spontaneous abortions are common, and together they account for an estimated 1/4 of pregnancies worldwide. And post-abortion family planning can help clients achieve their reproductive intentions, and it also provides cost saving. If we take the context of health system, the cost of the health system, like to provide abortion care, to provide treatment for complication of abortions, consumes significant amount of obstetric and gynecology budget of the health system. Whereas the post-abortion family planning under post-abortion care consumes only a fraction of the total budget. So these are the challenges which a country can address through post-abortion family planning. Next slide. Another challenge is that many post-abortion clients and health workers, they do not know that how soon a woman can become pregnant after abortion. In fact, after first trimester abortions, a woman within 2 weeks can become pregnant as soon as 10th or 11th day after abortion. After second trimester abortion, a woman can become pregnant within 4 weeks of abortion. And in case of medical method of abortion by mifepristone and misoprostol, a woman can become pregnant within 3 weeks. So what global data show that 2/3 of post-abortion clients, they did not know when fertility returns. And also, the data prove that women who leave the facilities without a clear understanding of pregnancy risk are almost 3 times more likely to have another abortion than women with accurate knowledge. Unsafe abortion is a major contributor to maternal morbidity and mortality. We know that around 10% of maternal deaths are due to unsafe abortion, and the range is from 4.7% to 13.2% of maternal deaths every year can be contributed to unsafe abortions. Unsafe abortion is the 5th leading cause of maternal mortality, and preventing unintended pregnancy, including among post-abortion clients, is fundamental to reduce consequences of unsafe abortions. The programs and countries which implement post-abortion family planning, high impact practice recommends these 2 indicators: that percentage of post-abortion clients who were counseled on family planning, and it would be best if it is disaggregated by age group below 20 years versus above 20 years. And second indicator is percentage of post-abortion clients who leave the facility with a modern contraceptive, again disaggregated by type of family planning method, and age group below 20 years and above 20 years. Next slide. Okay, so if you see the high impact practice brief, it gives us evidence of impact. I am not showing all evidences which are written on the high impact practice brief. You can visit the link and see the brief. I request my colleague Nalini to give the link in the chat box. So one evidence is it is from multiple countries. The data prove that acceptance of contraception is high when women are offered post-abortion family planning counseling and services. And I'm not sure if you can see the bar chart in the slide, but it is also given in the HIP brief that in these 7 countries where the post-abortion family planning counseling and services are in place at the facilities, a good percentage of post-abortion clients leave the facility with a modern contraceptive method. And the evidences are from Bangladesh, Ethiopia, Ghana, Guinea, India, Nepal, and Somalia. Next slide. Then another evidence of impact, that post-abortion family planning is scalable and sustainable. In the brief, if you read the brief, and I suggest that everyone should read that brief, this shows that in Peru, there were a project of technical assistance to strengthen post-abortion family planning services, and during the project, the interventions were implemented. But after the project also, the interventions and gains were sustained and it improved. Next slide. And the similar data came from Turkey also. The high implementation practice brief also gives the implementation tips, which is based on documented evidences and literatures from multiple countries. So I am not presenting all the implementation tips. So some of them are like invest in quality, and for that a wide range, offering a wide range of contraceptives is useful because it increases the acceptance of contraceptives. And this is very relevant for India because in 2016 to 2017, Government of India introduced injection DMPA in the name of Antara and pill Centroban in the name of Chaya in family planning basket of choice. And now you have heard that government has introduced implants and subcutaneous injection DMPA into the basket of choice. Second is encourage and support providers to treat all clients respectfully. And for this, the things which are useful but not limited to providers training, their value clarification to address providers bias. So, and the training can be reinforced through supportive supervision visits, clear job description, job aids, policies, guidelines, and other institutional support. Linking clients to resources to ongoing support. Whenever a client initiates, say, contraceptive, client should be informed about where to access ongoing support or resupply. And in that, our community health workers like ASHAs, ANMs, digital technology, helpline, they can be the means of support. Similarly, ensuring equitable access to all, regardless of client's age and local context. For example, in humanitarian situations, that women and girls are more prone to have unintended pregnancies and unsafe abortions. Another tip is address stigma by engaging with community and through community level workers. Next slide. So there are global resources. There is post-abortion care e-learning course in Global Health Learning Platform. Nalini can post the links for these resources. USAID's post-abortion care resource site and the Family Planning Global Handbook, which you have, my earlier speaker has said that it is considered as a Bible of information about contraceptive methods. These are global resources. Next slide. But we have resources available in our country. Government of India's Family Planning Division, Ministry of Health and Family Welfare site has these resources that which are Government of India materials. That is technical update on post-abortion family planning, then operational guidelines for post-abortion family planning, and the FP 2030 vision document. Post-pregnancy contraceptive services is one of the commitment which includes post-abortion family planning. Next slide. Next slide. Yeah. So thanks for your attention, and I'll suggest everyone to visit this site, and you will get the HIP brief on post-abortion care at this site. You can access the recorded webinar on post-abortion family planning. So and you can also download the PDF version of the HIP brief. Thank you.
Thank you so much, Sashwati, and thank you for a very comprehensive overview of the document, of the brief. Now I will move to the next topic, which is digital health for providers. For this particular brief, we have one of the authors of the brief, Smisha Agarwal, from the Center for Global Digital Health Innovation at Johns Hopkins University. Smisha couldn't be with us in person, but she has shared a recording that I will show right now.
Hello, everyone. My name is Smisha Agarwal. I'm an associate professor in the Department of International Health at Johns Hopkins, Bloomberg School of Public Health, and I'm also the director of the Center for Global Digital Health Innovation at Johns Hopkins. I am one of the authors for these high impact practices for family planning, and I'm presenting on behalf of my colleagues. So let's quickly get started first with the background of this. There is a growing body of evidence that digital tools can be used by providers and by various folks within the health system to improve adherence to quality of care, to improve availability of of family planning commodities and to overall improve family planning related care around family planning. Now, what do these digital health tools look like? So we've divided them, or we think of them in 3 different ways. So digital health tools, so starting at the bottom of these slides for clients, and that might include sending clients SMS messages, targeted client communication with the aim of improving knowledge, attitudes, behaviors, shifting norms, and reaching more and more people with the right information. At the level of the provider, types of digital interventions might look a little bit different. So there might be job aids, there might be communication tools where providers can communicate with each other for telemedicine, for example. Of course, digital tools, mobile phones specifically can be used to provide training, in-service training, as well as pre-service training. And then the use of digital data can help with decision making. And then at the systems level, digitization of data and availability of data at the right time can help with logistics management, improve data visualization and reporting, and overall, as a result of having the right data at the right time available to the right people, can really improve the efficiency, accountability, and transparency of health systems. This is a brief theory of change of how digital tools might address some of the barriers and improve impact or improve health outcomes at the client level. So you see here on the left, barriers might be inadequate training or limited demand, of limited quality of care due to a number of reasons, limited availability of data and transparency, and the types of digital tools I mentioned will yield improved resource allocation, improved quality of care, better trained providers, and improved decision making, thus yielding improved outcomes such as improvements in contraception use and reduction in unintended pregnancies. So let's get a little bit more specific. There are 4 types of digital enhancements that were studied under the high impact practices. We looked at digital job aids, digital communications tools, training, and availability of digital data. So digital job aids are essentially, they might include checklists, specific algorithms that allow providers to input patient level or client level information at the point of care, and based on a client's unique needs, recommend appropriate contraception or appropriate care overall. So based on a client's demographic, previous health history, experiences with contraceptive use, a digital job aid can help the provider recommend the right type of contraception, the right type of linkages to care, and also the right type of counseling around the use of contraception. It might also help a provider link the client to follow up for contraception use. So coming back after a month for a checkup or for more supplies, as an example. Digital communications tools. Fundamentally, digital communications tools can look very simple. It might just be a community health worker picking up a phone and calling their supervisor, right? It improves connection between providers. In a more formal system, there might be use of telehealth or telemedicine between providers, as well as between a provider and a patient, where a provider is able to remotely access a patient, or a patient is able to remotely access a provider, or a less trained provider is able to access a more trained provider, and so on. This is actually one of the stronger areas of where there is evidence, and just noting that I think at the time at which we summarized this high impact practice, it was pre-COVID. And since then, the landscape of telemedicine and what is available, what has been tested in the context of COVID-19 has really evolved. There's much stronger support for it now. Similarly, digital training, the pre-COVID and current world look vastly different, where we have a lot more experience as a global community in ensuring that providers have the right type of information to continue to update their knowledge. And so digital training is actually one of the areas of the use of digital tools that is largely uncontested. In fact, the WHO Digital Health Guidelines strongly recommend the use of digital training when appropriate, especially in service training, where providers do have access to a mobile phone and can access new and emerging information if there is new and emerging information to provide care. And then finally, the use of digital data, real-time collection of client data can really improve continuity of care, especially across levels of care. So for example, if a client is being referred by a community health worker to a facility, it can really improve that continuity and linkage of care. Availability of data can also help with efficient resource planning. So let's say if at the district level we see what the use of commodities is in a digital format on a monthly basis, we can anticipate and plan what resource allocation might look like in future months and ensure that commodities are available at the right time, at the right place. So I think that's largely the slides I have. One word of perhaps pause here is, as we're thinking about the use of digital tools for in the context of family planning, especially for interventions that are focused on clients, there is always a need to think about who's being left out, who are we not accessing, and issues of equity. Because even though we do have vast internet and data coverage in several countries and rapidly growing, and in India especially, there are still populations and people who are outside of connectivity. And I think as we are thinking about programs and making these plans, it's really important to consider who is being left out, especially in the case of family planning, where often our target audiences are women. We have to also think about some gendered aspects of access, where it's usually the male family members who might have more regular access to a mobile device. And so thinking about whether we are actually reaching the right populations with these interventions continues to be critical. I think it should not be ever just assumed. So while digital is the future in healthcare, and they are especially in the Indian ecosystem with ABDM, we expect to see a lot of progress on the digital front. I think it should always be with caution to ensure equity of access. So thank you very much, and my apologies that I'm not there in person to talk through any questions.
Great. Well, thank you very much. And we are coming to the end of the webinar. We have had some questions that have come to us through the chat, and our speakers have graciously answered those questions. So thank you very much for that. And now I'd like to turn it over to Dr. Prasad, who will give us the closing remarks. Dr. Prasad is the Chief of Programs at UNFPA India Country Office. I want to thank you for closing today's webinar and for staying with us through these 90 minutes. Over to you, Dr. Prasad.
Thank you, Edos. As we bring this insightful webinar to a close, I wish to extend a heartfelt gratitude on behalf of UNFPA India and WHO's Implementing Best Practices team to all the speakers, participants, and facilitators whose contribution has played a pivotal role in the success of this event. As we heard in the opening remarks, the webinar was timed around the World Contraception Day and was aimed at helping the Indian states to drop their interventions as they work towards achieving the FP 2030 commitments of India. In this context, the significance of high impact practices in shaping our family planning interventions cannot be overstated. High impact practices not only ensure results, but also serves as a wellspring of innovative ideas to promote reproductive choices for women. It's noteworthy that India's family planning program strategies that Dr. Pawan listed today aligns with many high impact practices. The recognition of this alignment led to a partnership between the WHO Implementing Best Practices team and UNFPA, along with the support of Ministry of Health and Family Welfare, Government of India for this webinar, which is a departure from IBBP's customary global webinars. We wish to express our gratitude to IBBP for their valuable collaboration. We especially would like to thank you, Ados May, for the pivotal role that you played in organizing the webinar and for skillfully moderating the sessions. I wish to express my sincere gratitude to Ms. Andrea Warner, UNFPA's resident representative for India and country director for Bhutan, for graciously allocating her time amidst her demanding schedules. We would also like to extend our appreciation to Dr. Pawan Kumar, Additional Commissioner of the Family Planning and Maternal Health Divisions at the Ministry of Health and Family Welfare, for his invaluable support and active participation in this webinar. Special thanks are due to our esteemed speakers of the technical sessions, for dedicating their valuable time to contribute to this event. Through this webinar, we received an overview of high impact practices and dwelled into details of 3 specific practices. While these HIPs are indeed important and serve as examples, it is crucial to emphasize that a comprehensive range of HIPs, including those specifically tailored to India and its family planning program, can be accessed on the FP High Impact Practices website that Ados mentioned. These resources offer valuable insights and guidance to enhance our ongoing efforts in the field of family planning. Let us collectively commit to further advance evidence-based interventions in family planning, which are guided by these practices. As we put these practices into action, it is imperative that we monitor and also share evidence from India with the global HIP community. This collaborative effort will enrich their repository of evidence and in turn benefit numerous countries. In conclusion, let us carry the spirit of collaboration and commitment from this webinar forward as we continue to work together to advance the family planning and reproductive health programs in India. Thank you once again, everyone, for your participation and dedication to this important cause. Thank you.
Thank you so much, Dr. Prasad. And before we close, I want to thank all our colleagues who presented, spoke, as well as the more than 90 participants who stayed with us through these 90 minutes. This is a great collaboration between a number of partners, and we're very proud to be part of this. You can find the presentation and recording on this link. I also have shared that through the chat, and it will be available later today or tomorrow. A reminder that these are the tools and resources for that we discussed today. And for more information, please visit the website, High Impact Practices, and learn a little bit more about how you can use these tools for implementation and policy making. We hope to continue the conversation on the collaboration and the knowledge sharing. We hope to learn more from India, as well as share some experiences from other countries in the region. And we'll be co-hosting an event on Wednesday, October 12th. And I will share that in a subsequent communication. With that, I would like to thank all of our speakers today again, and our audience for your participation. And until next time, thank you very much.
Thank you.
Thank you.